Good evening. I think it's very difficult to take the last lecture of the day. So I'll just try to make it brief and as clinically relevant as possible. So USGJ is primarily for palliation of outlet obstruction. Other options you have is endoscopic duodenal stenting, surgical GJ, and the EUS guided GJ, which we will discuss, is an alternative to surgery as well as duodenal stenting in patient with outlet obstruction. So why USGJ? It can be done in critically ill patients, short hospital stay, less painful, less invasive, bypasses the tumor, which leads to prolonged stent patency. And because of advancement in chemotherapy, the life expectancy of the patient has increased. Therefore, you want a procedure which carries long patency. How there are certain problems. One, need of a special device. As I showed, we don't have this double balloon, which possibly is the best way to do an EUS-GJ. Non-established, difficult endoscopic procedure cannot be done in complete obstruction because you need to pass a wire and then either a double balloon or a nasojejunal tube to do the procedure. And possible serious adverse events if you have mal-deployed stent. So before you do an USGJ, you need to do a CT scan in all patients. What do you want to look in CT scan? You want to look for diffuse malignant gastric involvement. If there is multiple sites of obstruction, it would be a waste to do a GJ then. Determine and the presence in the amount of ascites. In the presence of significant ascites, there is a risk of leakage and is a relative contraindication. So there are no definite guidelines nor consensus on the pre-procedure management. Clear liquid diet for a few days before the procedure, nil orally for a day before the procedure, a large bore nasogastric tube may be required in certain cases. Endotracheal intubation, as we did in this particular case, is warranted for patients with an increased risk of aspiration during the procedure. And what I would recommend that endotracheal intubation should be done in all these patients while performing a GJ, because you want a relatively stable patient, no movement altogether. So there are different sites for doing a GJ. It can either be a gastroduodenostomy, or it can be most commonly it's an EUS guided gastrojejunostomy. Therefore, one of the terms which is used for this is EUS guided gastroenterostomy, which covers both duodenostomy as well as the jejunostomy. So what are the devices that you need? EUS scope, hot axial stent. I don't think this procedure you should be doing with any other stent, usually 20 millimeter diameter, nasojejunal tube or endoscopic nasocystic drain that we have used in this particular case, or a specialized double balloon, which is not commercially available as of now, 19 gauge needle in certain cases, guide wire in certain cases, again, saline, contrast, and methylene blue. So as I mentioned, the two main issues while doing a GJ is locating the segment distal to the outlet obstruction, stabilizing the target loop for subsequent puncture and stent introduction. You want to stabilize the loop. So crucial step is sufficient dilatation of target loop, and that's what the double balloon technique does. It stabilizes the targeted loop well. A nasojejunal tube or a nasocystic catheter placed across the stricture beyond the ligament of Treats. Saline, as I mentioned, is instilled in small bowel directly through the scope positioned at the stricture level. Contrast mixed with saline to fluoroscopically depict the small bowel. Dye added to saline for visual confirmation of successful LAMPS deployment. The amount of fluid that usually is needed is up to 500 ml, and you may use Buscopan to decrease the peristalsis. So the three different techniques: direct technique, assisted EUS guided gastroenterostomy technique, which can be assisted by using a balloon catheter or a nasobiliary tube, as we did in this particular case, or an EUS guided balloon occluded gastrojejunostomy pass, that is known as E-pass technique. So first, A is direct EUS GJ, B is assisted EUS, and C is the E-pass technique. So direct technique, what are you doing? You are just going in the stomach, trying to puncture with a 19 gauge FNA needle, the bowel loop, distending the bowel loop with contrast saline, and then deploying the stent after passing the wire. So this is what the direct technique is. I would suggest this is possibly too theoretical, very difficult to do in the real life scenarios. The second is the balloon assisted. As you can see, when you have a non-distended bowel and you puncture it, it gets displaced. So that's the reason you want the bowel to be distended. And then once you can see after distension with the nasojejunal tube, you can see this. This is what we get. As you can see, this is significantly dilated bowel loop. And once you have this, you apply Doppler just to be sure that there's no intervening vessel, and puncture with the cautery enhanced device, and then deploy the distal flange. You just saw that live. And after the distal flange is deployed, you deploy the proximal end. So that's the procedure. Normally, this procedure does not take more than 5 minutes if everything is set. However, if you struggle at any step, this becomes a very difficult procedure. So this is what the deployed stent looks like. And then in this case, possibly we will be dilating also. So this is our initial cases. And what we did is after deployment of the stent, we chose to dilate this with a CRE balloon, which was 15 millimeter. And as you can see, if you dilate this, this opens up very nicely. And then you can enter into the bowel at the same go. So you can see now this is opened up totally. And then you can enter into the bowel as well. So this is not required because you may unnecessarily misplace the stent. So now you can see the nasojejunal tube which you had passed through this. So this confirms that you are in the right location. Then this is the US guided balloon occluded gastrojejunostomy bypass device. Total length 300 centimeters. Distance between the two balloons is 9 centimeters. And the maximum volume of the distal and the proximal balloon is 40 ml. So what primarily you do, you inflate these two balloons. As you can see in this imaging, pass the guide wire first, pass the double balloon, inflate the two balloon with contrast. And then this segment of the bowel, which is between the two balloons, this gets filled with water. And once it's filled with water, you puncture with the cautery enhanced device to establish the anastomosis. So you can do a barium. This is again one of our patients. You do a barium and you're clear that the barium is passing easily. And then after 2-3 days, you can easily go in across the site of the stent into the jejunal loop. You can go quite deep here. So, so this is how it looks like after you have placed the anastomosis. So post US, what's the strategy? GJ strategy is hospitalize patient overnight for observation, though there are now reports of patient being discharged on the same day. With 20 millimeter lamps, most patients may ultimately return to normal diet. You don't need PPI here in these settings, and patients are discharged home and then demonstrate adequate tolerance to oral diet. So in our hospital, we keep these patients for 2-3 days and then discharge. So what are the outcomes? If you see the various studies, technical success ranges from 87 to 94%, clinical success 81 to 92%. There are reports of misplacement of the stent, 36% in one series. Again, the adverse outcome can be pain, bleeding, and peritonitis. And the follow-up that is reported is 21 to 25 weeks as well. So this is a systematic review again, 2020 in digestive and liver disease. So this is 12 studies, 290 patients, all were retrospective, good technical success to the tune of 93%, clinical success 90%, adverse events 11%, mainly mild to moderate. The conclusion was US guided GJ has got high technical and clinical success, relatively safe, and might represents a non-inferior, minimally invasive alternative to surgery. This again, the recent meta-analysis that I was talking of in Endoscopy International Open 2022. US guided GJ versus surgical GJ in treatment of malignant outlet obstruction. 484 patients, US GJ in 291, surgical GJ in 193. Technical success of surgical GJ more than US GJ. Clinical success equivalent. Adverse events more in surgical GJ. Reintervention rate again same. So this slide is very, very important. It shows that US GJ has equivalent clinical success and reintervention rate, but significantly lower adverse event compared to surgical GJ. When feasible, US GJ appears to be an effective and safe alternative to surgical GJ for palliative management of malignant gastric outlet obstruction. Again, this study again a meta-analysis comparing duodenal stent versus endoscopic versus surgical GJ. Here, if you see the number of duodenal stent is the maximum is 477, US guided GJ 243, surgical GJ 818. Technical success, if you see, was the least with US GJ. 95% compared to 99% with duodenal SEMS and 99.9% with surgical GJ. The clinical success again was similar. USGJ had a lower rate of outlet recurrence, while duodenal SEMS had a higher rate of reintervention. So as I mentioned, this is a problem when the expected survival is more than 3 months. Overall procedure complications were similar. Estimated bleeding rate was lowest, and stent occlusion rate was highest for duodenal SEMS. So if you just compare the various studies, if you see short time to oral feed, short hospital stay applies both for self-expanding metal stent, that is duodenal stent, or USGJ. You have a short time to oral feed and short hospital stay. While if you see surgery, it's contraindicated in critical ill patients and has got a high complication rates. So this is again our study. So again, a high success rate. No significant no mortality here in our experience. So to summarize, USGJ may provide a more durable solution than antral stenting with shorter recovery time and less cost than surgical GJ. Patient must be chosen carefully and favorable anatomy is required to achieve clinical success. Before recommending this new innovative procedure as a standard of care, prospective randomized studies are warranted for. This is very, very important, which we should compare the various techniques of performing in the USGJ. As you know, there are 3 different techniques, and comparing the different modalities of treatment of outlet obstruction. Thank you.